Good morning, and welcome to today's discussion on the heart attack. So the focus of Psyfeld this morning will be on that selected Seinfeld episode. So I will open it up to the clerks in terms of anything you've seen, behavior or otherwise. What caught your eye, and what do you want to talk about? What do you want to open today's discussion with? In the context of these discussions, it absolutely does not have to do anything with your clinical observation. I hope that nobody necessarily prepared in a way that you tried to study behavior, you tried to review and get an idea of what topics that we should talk about. The start of any of these discussions is only to talk about what you found funny or what you found interesting, and just see where that conversation takes us. So any of the clerks have any thought as to where they would like to start?
Hi, I guess I know in the beginning of the episode, I forget his name, but the older guy like saw something on TV about a heart attack, like an infomercial or something, and then like the next morning during breakfast, he had like classic heart attack symptoms and had to go to the ER for it and had the negative workup.
Okay, and one of the things when we begin to formulate what that might mean from a clinical perspective is to basically come into the conversation or begin our thought process at a point where we regard whatever we're viewing, whatever we're observing, or whatever we're hearing from our patient to be normal. So even if the presentation is as abnormal as a textbook could make it, I would like every clerk to start the conversation, to start their critical thinking at that point where you believe the patient or the patient's behavior is within normal limits, right? Now, when we move toward abnormality, when you begin to identify that an individual is presenting perhaps even with a full-blown and acute mental disorder, there are a few things that we have to look for. All right. So what are the things that we will be observing that move us off that initial starting point? And one is if the behavior is recurring. Any behavior in a vacuum is not likely to come to the attention of a psychiatrist. Or if it does, the psychiatrist may reassure and say that there's nothing to do today, or there's nothing to do now. But let's have you have a follow-up, and let's just watch the way things may evolve. Is there any evidence in this scene? Is there anything in the conversation that George, that's the character you've identified, and Jerry, to suggest that this is recurring?
Yeah, I think Jerry and Elaine's reaction suggests that this is sort of typical of George. Like, he's a hypochondriac. They don't believe him. What struck me and my wife was that they were so mean to him, and they didn't even try and comfort him. They just like immediately were mean.
Yeah, and for those who have watched Seinfeld before, and this is an early season episode, but nonetheless, in prior episodes, George has established this type of behavior where his closest friends, his childhood friend, high school friend, Jerry, and Jerry's friend, that is his ex-girlfriend, Elaine, who George also knows for a while. This is a parallel in psychiatry, that when a patient presents with a potential problematic behavior, you contact people that know the individual the best, collateral information. And both Jerry and Elaine would have disclosed to you that this is not a behavior in a vacuum, that this is actually recurrent. And I think, and please correct me if I'm mistaken, because I might be thinking about one of those other episodes, but Jerry makes a comment on how he had previously seen something as a documentary, and then the next day thought he had that. So in this case, not much difference here, and certainly consistent with repetitive or recurrent behavior. Now, once this is established, the next question to ask is it clinically significant? And clinical significance in psychiatry is operationalized as causing impairment in functioning. Okay, so clinically significant distress or impairment in functioning. Yes or no? Do you think that George's behavior is clinically significant?
I would say yes, just because it's like impacting, like it's clearly impacting his life. Like he went to the hospital. It's like, it's not like some little thing where he listens to like Jerry and Elaine. It's like he goes to the hospital, he probably has to like call off work, like there's a bill associated with that, so on, like so forth. Now,
in George's defense, in this particular case, it appears as though he has tonsillitis. But nonetheless, I think the answer is yes here, because even in this particular, and there's a teaching point here as well, a clinical pearl, even though things turn out differently this time, in previous occasion, George was found to have nothing wrong with him, and was burdened by the level of distress that resulted from his actions. So the answer is yes here. However, quick clinical pearl. If someone comes in with this condition, and we're going to get to pretty much what we're talking about in just a second, but if somebody comes in with this form of mental disorder, one of the things that clinicians, psychiatrists alike, must consider is that even with an established diagnosis, and again, this is a diagnosis that we're about to make in this particular situation, in this selected episode, that individuals with this pre-existing condition can still get sick. So if the physician, perhaps knowing George, was quote unquote reassuring and turned him away saying nothing further to do, let's watch this, he may have presented to the ER a day or a week later with a more acute infection or a more acute inflammation. So it's a clinical pearl. Be very careful where we're going with this, because people who have mental illness do get sick, that is from a physical cause as well. So I know that sounds obvious to third-year medical students, but unfortunately, sometimes the way medicine is practiced is inconsistent with that gold standard.
I have a question.
Please.
Is there any scenario in which somebody comes to the hospital with chest pain and you don't do an EKG and get troponins? Like, yeah, okay, you know George is a hypochondriac, but surely it's too risky to miss a heart attack.
Yeah, so the answer is yes, and I've seen this, but again, it's a little bit of aggressive therapy, and not everyone would be on the same page, and this does require coordinated care. I've seen patients before with this condition present and overutilize resources in the emergency department. And I've been part of a team that made a cost-effective decision that they go to cardiac cath. Even though many thought maybe this wasn't indicated, once the individual was found to have clean coronaries, the ER docs felt much more comfortable 24 hours later when they returned with chief complaint of chest pain that was of similar or the same quality of prior pain, to reassure and say your catheterization is completely clean, and on occasion did not get an EKG. But that is a very, very rare circumstance, and it is a product of a treatment plan that, even though it was deemed cost effective, is not common practice. And oh, by the way, in those patients, they were never diabetic, right? No silent MIs or no concerns there. The pre-test probability, if you will, the risk factor assessment was quite low, age, cardiac risk factors, etc. But very rare, but yes. Next step, from normality to abnormal behavior, recurrent and clinically significant, is to now try to focus on what is going on. And I think here we should challenge ourselves and think through this observation, this behavior, as perhaps being part of a mood anxiety cluster versus a psychotic dissociative cluster. And even though all of behavior cannot be simply contained within those two subdivisions, at this point in our critical thinking, it's a really good idea to try perhaps to pigeonhole what we are observing into one of those two clusters. So if you were made to make a commitment, A, mood anxiety, B, psychotic dissociative. Anyone? Is what we're observing in George more likely to be an illness that is described or categorized in a mood anxiety cluster or a B, psychotic dissociative cluster? There's no wrong answer here. You just have to make a commitment in terms of getting to the next step of our critical thinking.
I feel like because he believes that he doesn't have a heart attack at the end, then you take out psychotic or delusions.
You would take out psychotic? Is that-
Like you wouldn't think he was psychotic or had delusions, because I thought delusions you have to believe in the face of like proof that it's not true.
You're exactly right. Right. So if you're going to remove B, we're left with choice A. Now there's steps to go from here, but due to time constraints this morning, if we're thinking that George is afflicted with a mood anxiety cluster, we now have to again streamline what the most likely diagnosis is. And I heard someone mention it before. It's the illness that was previously referred to as hypochondriasis. Now, hypochondriasis, the former name, was categorized as part of the somatic symptom and related disorders chapter, previously known as the somatoform disorders chapter. In 2013, with the revision to the DSM-5, that condition, hypochondriasis, underwent a name change. It is now called illness anxiety disorder, and it was removed from the somatoform disorders chapter, and as the name implies, was placed in the anxiety disorders chapter. So what we're seeing here is likely the manifestation of an underlying anxiety disorder, one previously known as hypochondriasis, currently identified and diagnosed as illness anxiety disorder. Individuals like George who are struggling with illness anxiety disorder have a preoccupation. They have a preoccupation with either having or acquiring a severe illness. And it's that preoccupation, it's that anxiety that is the focus of clinical attention. And that pretty much textbook, board exam, shelf exam is what's going on here. So that opening scene is likely a manifestation of illness anxiety disorder. Again, individuals with established illness anxiety disorder can get tonsillitis. They can get sick. So even if an individual is in treatment for illness anxiety disorder, if they present to you with a chief complaint of blank, you have to adhere to the DSM. You have to adhere to the American Psychiatric Association published guidelines and always evaluate for and definitively rule out an organic pathology. Organic here means underlying medical conditions such as tonsillitis, or that the presentation isn't due to the direct and physiologic effects of a substance. And once they are investigated, and once those two organic pathologies are ruled out, then you could focus on the mental disorder, in this case, illness anxiety disorder. Any questions about George?
I have a question about like the diagnosis and whatnot. So I understand like why this is illness anxiety disorder, but if he's like truly having chest pain or like physiologic symptoms, would that more bring in like the conversion disorder discussion? Like I'm in terms of conversion disorder, that's why I don't know like where the line sort of is.
Yeah, and yeah, that's a great point. The illness anxiety disorder, the primary focus is on the individual's thinking. That is, it's a preoccupation. And the individual's thinking can actually evolve in severity And that preoccupation itself may evolve into a delusion, right? But it's the individual's thought content, the preoccupation, that is defining of the condition. For other conditions in that chapter that I previously referenced, now titled Somatic Symptom and Related Disorders, the focus is on the patient's complaints, their actual somatic symptoms, not their thinking behind the symptoms. That's where the split lies. If an individual has multiple somatic complaints, which have no underlying physiologic explanation, that's called somatic symptom disorder. If their physical complaints happen to be of voluntary motor and or sensory function, right? If that specific variant, then a subtype of somatic symptom is the most likely diagnosis, and that's called conversion disorder. But in either case, the focus is on the patient's complaints, not their thinking or thoughts behind those complaints. It's a fine line. Individuals, one of the ways in which practitioners may delineate that line, right? The thinking from the actual somatic complaints is the individual's affect. There are 5 domains of affect that you have to know that people like me will expect you to report on when you present a patient history. One is the type of affect, right? So very generic adjectives here. So dysphoric, actually, let me start with what is considered to be the baseline or normal, and that's euthymic, right? Euthymic is normal. Abnormal types of affect include dysphoric, anxious, and irritable. Those are the 3 most common adjectives used to describe one's type of affect. The second domain of affect is the range. Normal here goes by the clinical term of broad, right? That is, during the course of a conversation, history and physical, an individual's intensity will wax and wane. That's showing a normal or broad range. When those peaks and troughs are very similar, if they both regress to the proverbial mean, and their intensity when they're peaking isn't that much different from their intensity when they're in that trough, that's considered to be a restricted or constricted range. The third domain is intensity itself. Intensity itself. Again, an individual may demonstrate normal intensity. On the other hand, if they demonstrate abnormal intensity and it is below average, we call that blunted. Figure if the average intensity, the average grade is a C, if their intensity is a D, below normal, blunted. If it's an F, if it's significantly below normal, we call that flat. Right? So blunted and flat are degrees of abnormal intensity, from a C to a D to an F. What differentiates a D from an F? Your guess is as good as mine. There's nothing established in the medical literature that delineates that. Change pattern. The 4th domain is change pattern. Individuals can flip from a peak to a trough rapidly. That's called labile or mood lability. It's a little bit of a misnomer. It's actually affective lability. The opposite, when they take abnormally long to switch from their peak to their trough, is called over-controlled. Over-controlled. And then finally, that 5th domain is congruency, otherwise referred to as appropriateness. Is the individual's affect euthymia consistent with the content of the conversation? If it is, it's considered to be congruent or appropriate. If not, incongruent, inappropriate. Again, those terms are interchangeable. Now, let's get back to George and let's get back to illness anxiety and illness anxiety versus either somatic symptom disorder or conversion disorder. In illness anxiety disorder, and we'll look at George here, the individual's affect here is anxious and intense. It's abnormal. It's appropriate, that is, it's congruent. On the other hand, an individual with somatic symptom disorder, an individual who is presenting not with their thoughts, but with complaints, specifically somatic complaints, will often have an affect that is either normal or blunted, that is normal intensity or perhaps even blunted intensity. And that'll leave the practitioner scratching their head a bit. How could someone with these complaints be acting like that? That is incongruent, right? That is an inappropriate affect. And that's what really differentiates these two conditions. Matter of fact, that is so differentiating that we actually include another clinical term to really imply not only the abnormality, but that differentiation from illness anxiety disorder, and it's called labella indifferens. It's the individual not having an intense affect, and the individual therefore not being congruent. And when those two come together, labella indifferens is the clinical descriptor of one's affect in the setting of either somatic symptom disorder or its subtype called conversion disorder. Questions about affect, questions about somatic symptom or related disorders?
I just
we
had
had
a
a
question. Sorry, I just had a question about, I guess, like, to what extent do you include something like somatic symptom disorder in a patient's history? I don't know, Liana, if this is what you're going to ask, but we had a patient, like, a differential was conversion disorder, and I guess we were kind of warned against including that in any notes or documentation, just in case they had actual legitimate complaints and they wouldn't be taken seriously. So yeah, I just wanted to see what your thoughts are on that.
Yeah, and that gets to my point that I originally made. If that is a diagnosis, please provide it in the medical record documentation. Again, psychiatrists should be practicing like quote unquote real doctors. If a diagnosis is made, this idea of I may or may not include it in my paperwork, in my medical record documentation is a ridiculous conversation to have. However, in this situation, because of the prejudice and stigma toward people with mental illness, if you are considering the diagnosis and have not made it, then I agree. Don't put it in, because you could make the argument that more harm can come of this than good. Remember, the medical record documents are just a form of communication between physicians. It's all they are, right? And that's a terrific benefit, so that when the individual at a later time at a different place presents with A, B, or C, the medical record helps communicate to the new physician, whether it's in the ER, whether it's a newly established primary care, it doesn't matter. That's a great benefit. As a practitioner, as a psychiatrist in this situation, you have to consider whether or not the risks outweigh that benefit. And those risks may in fact outweigh that benefit when you do not have a diagnosis but are considering one, right? So it's a good point, but I think the bottom line is that if you are making a diagnosis, to withhold it from the medical record and therefore set up a scenario where there's likely to be miscommunication, that's not good practice. There was another question?
My question was also about conversion disorder. We had the same thing. They told us not to put it in the in the record because we were just considering it. But I was looking up labella indifferens, and what I saw in UpToDate was that there's no difference between people with neurologic symptoms with an organic cause and people with neurologic symptoms with conversion disorder and labella indifferens. So not to use that as like a marker of whether or not, you know, quote unquote, the symptoms are real, but is it still a useful tool in distinguishing between, like what you were saying, illness, anxiety disorder, and conversion disorder type thing?
Yeah, yes, definitely. Yeah, you're exactly right. Depending on where the neurological insult is, depending on where the focus is, let's say the amygdala. Yeah, an individual can actually present with labella deferens even when they have an organic or neurological insult. So yes, you have to be careful there. And again, all of these are clinical findings. No clinical or physical exam finding should be ever interpreted in a vacuum. There's no degree of specificity there. They have to be taken into context with a full psychiatric evaluation. Right? So, and that's where findings of the mental status exam, including those pertaining to affect, the way they also should be interpreted. But there is some degree of efficacy in focusing on affect in general, and perhaps labella deferens in particular, when distinguishing somatic symptom and related disorders, including conversion, from hypochondriasis. That comes up on shelf exams fairly frequently. And the reason why is because it is consistent in clinical practice.
Thank you. I actually have one more question about conversion disorder, which was when I was reading about it, it seemed like there was a heavy emphasis on neurologic symptoms, but I'm wondering how often you see, you know, just as, you know, non-neurologic symptoms as a part of conversion disorder.
Well, I mean, by definition, pretty much 0% of the time, because when conversion presents with non-neurologic symptoms, for example, GI symptoms, we simply don't call it conversion disorder. That's called somatic symptom disorder. So in that context, and even though the American Psychiatric Association doesn't really do this, they actually publish these as two separate conditions. The fact is that conversion disorder is a subtype of somatic symptom disorder. When an individual presents with one or more somatic complaints for which no underlying physical cause can be found to explain it or them, we call that somatic symptom disorder. When the individual's physical complaints are specific to voluntary motor and or sensory function, then it's called conversion disorder. So in that regard, conversion is a subset of somatic symptom disorder. So someone with quote unquote conversion disorder will not be presenting to you with complaints outside of voluntary motor or sensory function, because if and when they do, we don't say it's conversion disorder. We use the more general description or descriptor of somatic symptom disorder.
Thanks, that's really clear. Sorry if I missed that earlier in the conversation.
No worries. All right, it actually took us right down to the bottom of the hour. So we usually get to more than one of the characters. I will open this up then to rounds. If there are more questions about Seinfeld related to characters other than George, please feel free to pimp me in terms of what you saw and maybe lend some explanation, and therefore we can reach teaching points outside of the somatic symptom and related disorders chapter. This was a great discussion. Again, the fact that we can dedicate an entire half hour to a single character, and in this case, his behavior, I think this is a great start to your clerkship. So for the red team, let's figure on beginning table rounds at about 9:15. I'll be in then, and we'll take it from there. Thank you, everyone.